Adapt NCLEX, and thank you for joining us. 6 endocrine medication that you're supposed to know. If you don't know at all, if you're doing endocrine, there's some few medications you have to know. Planning to take your NCLEX, don't forget these 6 endocrine medication. First one is insulin. Everybody know about insulin. What are they going to ask you? I try to make the note very short, sweet, and precise and concise as much as possible. But these single slide has everything you need to know about insulin that they will ask you. I intentionally do it that way so that you have test-taking strategy, key facts. You don't have to watch a long video. Insulin is used for type 1, type 2 diabetes. Remember, not every medication that can control your glucose is good for type 1, type 2, but insulin itself is good for type 1, type 2. There's different kinds, different classes. You don't have to memorize them. Just classify them in your brain. There's those that are very short acting. That means he acts very short. That means you have to think about it. If I give it to you, it's going to do its job. And if it's going to do its job, what would he do? It's going to decrease your glucose. Therefore, if your glucose is already low and I gave it to you, it's going to drop your glucose and you have hypoglycemia. Therefore, if it's a short acting, that means if I give it to you, you have to replace your glucose, at least bring it up. So that's why you have to eat with it. There's some that are rapid acting, some that are intermediate, and some that are long acting. So how do you remember them? The first one is what? Rapid acting. That means very quick, very fast, and it will do its job very quickly. What do you think about them? There's a way you can remember them. I call them lag, right? Lispro, aspart, and glulicin. These are the very rapid acting because they're going to act right away. You give it with food. So you give it to them, then they have to eat right away. It's onset, very, very quick. Within 15 minutes, he's doing his job. And so this is the onset. It's going to take between 1 to 3 hours to pick. So if I give it to you, you start to work slowly and then it will pick. That means at this point, you have maximum concentration of the medication and the maximum concentration of the medication is doing its job. So you should expect hypoglycemia at this stage. And therefore, if they ask you, when are you going to see this patient? It's this time. Then it starts to go down. So this is where they're going to pick 1 to 3 hours. So if I give it to you at 2 hours time or maybe 1 hour, 30 minutes, I'm going to see you. And then it's going to last for 3 to 5 hours. So the peak, if you draw this line, it will be here, right? 1 to 3 hours. So you got to pick your poison. Where are you going to see this patient? Is between that point. So these are the rapid acting. Lespro, I call them lag, aspart, and glulicin. The key concept, give with food. Know that they start acting quickly within 15 minutes, then the peak within 1 to 3 hours, and it lasts 3 to 5 hours. The short acting usually, mostly, is a regular insulin, right? It's the regular insulin. That's the most common one that we all know. It's short acting. It's the only one is okay to give as IV. And therefore, somebody have a DKA, this is the one you can give it to. You have to give it to them when they have DKA. So DKA HHS. The onset, as you can see, 30 minutes. So it takes a little bit longer compared to rapid acting. And then they peak between 2 to 4 hours, and then this is the duration. The intermediate is NPH. That's the only one, right? And usually the best way to remember for your board is the very cloudy, the long acting. They act like long acting is intermediate. So this can be given twice a day, Q12. And you can mix it with the regular insulin. You can mix it with it. The long acting, I call them the double DG, right? Determine and glargine. The best way to remember them, I will know the rapid acting. If you know rapid acting and you know regular insulin, any other insulin they give you apart from NPH, you know that is a long acting. So that they don't trap you, I will know the lag, forget about the long acting, and know that NPH, so that when they give you anything, determine glargine, you know it's a long acting. What's that mean? There's no pick. You don't need to eat with it. So if they trap you, who do you see? Patient is on glargine and he's ready to eat. Who are you going to see? Forget about it. Let them eat. Later on, give them insulin. And you should not mix it with any other insulin. The key thing is most of them is sub-Q. You got to inject them. Like I said, the regular one is the one you give them through IV. And then when you mix in, you just have to draw the RN, right? RN draw up regular insulin before NPH. That is the body will ask you, which one do you mix? When you mix in insulin with NPH, you draw the regular one before NPH. This is all that you need for the NCLEX regarding insulin. Okay, so that's the first one. Second endocrine medication supposed to know is metformin. Some people call it glucophage. That's the old name. I don't think they will give you glucophage. They will use metformin. That's the number one. And this is usually is an oral medication, so it's very good for type 2 diabetes. What are the key things you have to know? A head contrast. Okay. A head contrast. And therefore, hold it before and after contrast dye, or before surgery and after surgery, and you have to wait 48 hours. Watch that trap. Both contrast and surgery. So if you're going to have surgery, you got to hold it for before at least 2 days, and then after 2 days. Why? Because it leads to what? Lactic acidosis. Because of that, it can cause really bad condition, affect your kidney and other things. So lactic acidosis is really real. Because of that, your board is going to ask you, look, the board exams focus on key things that affect a lot of people. So you expect them when they give you metformin, they're going to ask you lactic acidosis. Don't forget about it. The key thing is about insulin is if they don't release what diabetes medication, if they don't release insulin, they don't cause weight gain, they don't cause what hypoglycemia. Metformin does not cause weight gain, right? It does not cause hypoglycemia because it does not release insulin. What it does is improve insulin sensitivity. So this is why it's very good for type 2 diabetes, because that's the main cause of type 2 diabetes, insulin resistance. So if you decrease the resistance and you increase sensitivity, it's going to help. So I call it metformin. It tastes metallic and no dye for it. So 2 medications that you're supposed to know. You can't go take the NCLEX without this guy, levothyroxine. A bunch of people are on thyroid medication, and most common one is Synthroid, levothyroxine. Who takes it? Is a thyroid hormone, is a hormone, is a steroid, right? People who take this medication, they don't have thyroid hormone. What does the thyroid hormone does? It control everything in your system, your heart rate, your metabolism, your breathing, your reflexes, and everything. What is the board going to ask you? Key concept, right? When do you take it is very important, because you got to teach the patient how to take it and what to avoid to prevent absorption. Number one, you cannot take iron with it. You cannot take calcium with it. You cannot take antacid. These 3 things, know it. You can't take it together. It does not mean you cannot take antacid. It means you shouldn't take it within that time, within the time you're taking levothyroxine. So you got to wait at least 4 hours, because it's going to take like almost 2 hours to absorb it out of your system, in your stomach. So you have to wait for that. The best time is in the morning, empty stomach. So if you want to eat, wait 30 minutes, then you can eat. But the best thing is in the morning, empty stomach as much as possible. Don't forget, in the morning, empty stomach. It's a thyroid hormone. If I'm giving to you prioritization, when they ask you the question, look for side effect of that. The thyroid hormone is going to speed things up. So if I give it to you and you're losing too much weight, we got to intervene. You're getting more tachycardic, we got to intervene. You're getting more palpitation, we got to intervene. But look at the way they frame the question. If I give you thyroid hormone, I expect you to get a lose weight. But there's a certain point, the way the answer choice will tell you it means this is a priority. So pay attention. These tricks is an expected finding to lose weight if you're getting thyroid hormone. But how far do you go? They're going to put information in the question that you will know that, oh, this is a priority. So watch for that. The last thing about it is anybody on levothyroxine, it means they are hypothyroid. You don't have thyroid hormone anymore. If you stop taking it, you are in trouble. So it's a lifelong medication. What will happen to the patient when they stop taking their thyroid hormone? What do you think? What do you expect? Stop your thyroid hormone. So you stop the levothyroxine right away. Who knows what kind of symptoms or condition is associated with this problem? Patient has hypothyroid, is on levothyroxine. All of a sudden, they stop taking the thyroid hormone, maybe for 2 days. What do you think the condition would be? Expect question like that. Expect NCLEX to give you a case study like that. If they give you a case study, they may take you there. I'm taking thyroid hormone. I stop it for 2 days. All of a sudden, what would I show? What are the signs and symptoms? Or what do you call the condition? What will happen? How would the patient present? We call it what? Your heart rate goes down, your blood pressure goes down, your respiratory rate goes down, your temperature go down, you get confused. So confusion, you become lethargic. What do you call all these signs? What do you think? They will be hypoglycemic. This is what we call mesothelioma coma. So they go into mesothelioma coma. This is a side effect of hypothyroidism and stopping your medication right away. So don't forget, if you need more what it means, mesothelioma coma, check out Dr. NCLEX. I have a video on endocrine. There's a playlist that has everything. This is another medication that we can use for thyroid hormone. Instead of having hypothyroid, this one you have too much thyroid hormones. And so you have hyperthyroid. Your symptoms is going to go up. You're going to have HAPS going symptoms, right? You have what? The only thing that will happen is your heart rate goes up. You have palpitation. You sweat, right? But your weight goes down. Hyperthyroidism. If it's a grave disease, you're going to have what? Loss of thalamus. How do I treat your problem? I need to block your thyroid hormones. And this is what we use, Methimazole or PTU, propriethyrouracil. Is going to block the thyroid hormone. I effectively, essentially, I turn you into hypothyroid. And that's what the medication is doing. They may ask you key question. This thing, agranulocytosis. Methimazole and PTU causes agranulocytosis. And so watch for signs and symptoms of infection. So you monitor their white count. Don't forget it. Therefore, if they have sore throat, fever, priority for a patient on methimazole, that is the key aspect of it. If they give it to you and they take you to a pregnancy, maternity, watch it. You see how these cross over to maternity, watch it. Not every pregnant lady who have hyperthyroidism can take PTU or methimazole. Find what kind of trimester they are in. If it's a first trimester, is safe. PTU is safe. If it's second trimester above, then you can give it Methimazole. This is a key concept you have to know regarding the use of this medication in a patient with hypothyroid. So what is PTU? Put the thyroid on under. That means slow it down. Once again, these are adapting class 6 endocrine medications you really have to know if you are in a nursing school or if you're preparing to take the NCLEX, if you don't know. Everybody knows steroid. You do Addison disease, you're Cushing, they're going to ask you, what is the main use of it? Patient who likes steroid. In endocrine, it's used for Addison. What are the side effects? Don't forget, they're going to ask you Cushing syndrome or patient with Addison is on steroid. What will be their symptoms? They have too much steroid. And what does that do? It's going to cause so many things. You're going to gain weight, right? You get buffalo hams, right? Abdominal striae. I can list all of them, right? GI bleed, right? All of them, weight gain. Your blood pressure goes up. Water retention. All these things you should be able to ramble them. Nobody should even tell you. As soon as you hear steroid, you should be able to list them. This is telling me that you're ready to go take. These are the way you have to study. Like you say, oh, steroid. What should I expect? You can jot down at least 5, 6 things about it, and the board will ask you that, right? Don't forget osteoporosis. Your glucose is going to go down. Your sodium is going to go up. Your potassium may go down. And the key teaching moment, taper it. Don't stop it. If you stop it, you develop Addison crisis. These are teaching moments you have to know. Remember, when I give you steroid, certain things can happen. Your white count can go up. So you have leukocytosis. So patients on steroid have leukocytosis. But just know that hyperglycemia, immunosuppression, you're more likely to get infection and osteoporosis. A bunch of people have had steroid and its side effects, some side effect, they can't recognize it. There's another one, cataract. You can have cataract or osteoporosis. And you should avoid NSAID because you can have GI bleed with a steroid. Once again, these are medication. I want you to know them. You've seen this before. I know you watched some video. They mentioned Desmopressin. You know what it's used for. What is that? Diabetes insipidus. What is Desmopressin? It's the same thing like ADH, right? It's going to hold on to the water. What can it be used for? The DI, diabetes insipidus, like central diabetes insipidus, right? Nocturnal enuresis, kids who wet their bed, we can give them this medication. This is a pediatric question too that they can ask you. You see how it cross over to so many things. That means you should know that medication. You can use it for diabetes insipidus. You can use it for nocturnal enuresis. And of course, hematology. If you have Willebrand disease, like bleeding disorder or hemophilia A, you can still use it because it helps with production of von Willebrand factor and help with your platelets. So something you're supposed to know. If it's ADH, like I said, water retention. Another question people they've asked them is about this. There's a different form. There's an oral. You can take it by mouth. You can put it in your nose, intranasal. You can get IV form. You can inject it. Know all the forms and contraindication. If the patient has sinus and they congested, well, you cannot give it to them intranasally, or if they ask you the question, patient is getting it through the nose, but he has too much stuffy nose. That means he cannot absorb it. Give them something else, sub-Q injection or IV or oral. So use your critical thinking here. You're going to hold on to water, so your urine output is going to decrease. And what is going to happen? You're going to gain weight, right? Their sodium is going to go down. That is your priority. They will have hyponatremia. So any patient on desmopressin, what should be your number one? Think about it. What should you prioritize as a nursing occur, what should you prioritize? Prevent hyponatremia. That means you got to watch them, check their labs, and then seizure precaution because they're going to do what? Develop hyponatremia. So you have to institute seizure precaution, and that is your priority. So those are the key things you have to worry about. That's why I put it there. DDAVP, that's another name, is going to decrease diuresis, right? In a patient who has DI, but at the same time, it's going to help your platelet. That's why you can use it in what? Von Willebrand disease. And these are the 6 questions, few questions to emphasize those information that we talk about. 6 medication, master them, endocrine will be golden. This is and the first question. A client with hypothyroidism is prescribed what? Levothyroxine. I told you this is for patients who need thyroid hormone. When do you take it? Which the instructions should the next include? You take it with food, right? You take it at bedtime, right? You take it with calcium supplement, or you take it on an empty stomach in the morning. What do you think? Put down your answer, let me know. Yes, explain it. The most important time to take it is what your body is going to ask you. What things you should avoid is what they're going to ask you. What side effect should you expect is going to ask you. They're going to ask you. The most important thing is don't forget to teach the patient to take it at the right time. And therefore, the best time to take it is what? Empty stomach in the morning. So option D is the right answer. How about this one? A client with diabetes insipidus is receiving desmopressin, DDAVP, right? That's like ADH. You give them ADH. Which of these should you worry about? Let me see what you think. You can put your answer down. But which of these information? I give you DDAVP. Which finding require intervention, prioritization? Is their urine output 400 in 8 hours? Or their sodium is 125? Or they've gained 1 pound in 5 days? Or they complain of nasal dryness? If you have to pick one thing, if you have 1 second, which of these patients, which of these findings should concern you? That's all. Is the urine output, the sodium level, weight gain, and complaint of dryness, right? Complaint of dryness. So which of this do you think is the most important? The urine output of 400 over 8 hours, if you calculate, it's not bad, right? Almost like 50 ml per hour. It's still not bad. Sodium of 125, that's severe hyponatremia, right? Weight gain 1 pound in 5 days is not bad. Your nose is dry. I'll give it to you another form. Sodium 125, you're going to have seizures. You should intervene. So that one, I don't like it. How about this? Which lab value is most concerning? And as is receiving labs for a patient on Methimazole for hyperthyroidism. So they're taking what? Methimazole. Which lab value is most concerning? Methimazole is used for hyperthyroidism. There's one side effect you should never forget. Same thing as PTU. They're very dangerous. You have to watch it during pregnancy, but there's one thing you should not forget. Diaphoresis, the VBC of 2000, palpitation, and weight loss. Which of these should you worry about? Look at each question. Diaphoresis. Well, if you have hyperthyroidism, you're going to have diaphoresis. If you have hyperthyroidism, you're not going to have the VBC of 2000. If you have hyperthyroidism, you're going to have palpitation. If you have hyperthyroidism, you're going to lose weight. You see how you can tackle the question? All the symptoms, diaphoresis, palpitation, and weight loss is associated with hyperthyroidism. The question is asking you about what? Methimazole. That's what it's asking. So pick an answer choice that is related to what? Methimazole. Methimazole, if I give it to you, it will block thyroid hormone. So you shouldn't be sweating. You shouldn't be having palpitation. You shouldn't be losing weight. But one side effect about that is agranulocytosis. And agranulocytosis is white count of 2000. So that one is your answer. And the last question. Don't get trapped, right? Which of the following findings should cause the nurse to question the what? The prescription. That means the key word here is question it. I need to question the prescription that is provided. And nurse receiving lab results for a client with what? Type 2 diabetes who is scheduled to start what? Metformin. Underline the keywords. Break down the question. Spend some time to figure out what the question is asking you. The question says what? I need to question the prescription and which finding in the patient bears with type 2 diabetes about to start what? Metformin. Connect it together. I have type 2 diabetes. I want to start metformin, which finding will let me question it. This is what we have. Hemoglobin A1C of 9.3. Should that make me question the use of metformin? Creatinine of 2. Should that make me question the use of metformin? Potassium 4.3. Should that make me question the use of metformin? Fasting glucose of 200. Should that make me question the use of metformin? Think about it. This is a question requiring some critical thinking. Don't worry about the numbers. Look at what the question is asking you. That means rewrite it. If I have to give you metformin, which of these will let me question, say, hey, I can't give it to you? Then you think about it. What is the major side effect of metformin? Lactic acidosis. I need to hold contrast. If I'm going to give you contrast, I need to stop it. If I'm going to have surgery, I need to stop it and wait for 48 hours. But which condition in this situation will make me question this? Well, if your hemoglobin A1C is 9.3, it means you need insulin. Metformin will help you. I'm not going to stop it. Potassium 4.3, metformin does not affect your potassium unless it affects your kidney. It does not. If your glucose is 200, I need to give you the metformin. It should not be a problem. But if your creatinine is 2, it means your kidney is not working. If your kidney is not working, so you have kidney problem, it's not working, that means I'm more likely to have lactic acidosis, which is the side effect of metformin. So poor kidney function will increase the ability to cause lactic acidosis. And therefore, I should hold this. Don't forget about this and that and that. So this is the way you should apply the concepts to answer the question. 6 medications for endocrine. Thank you for watching. If you need more, join Adapt NCLEX membership. There's 6 videos on nursing concept regarding pharmacology medication you need to know. 6 of them for each system. And good luck in your exams. Bye.